Well, so this trial is going to be followed for 10 years, and so we're going to get some really good data. We chose a 2-year endpoint of all-cause mortality or disabling stroke at 2 years because this is a low-risk population, and we thought we needed to choose very objective measurements. Death and disabling stroke, they're objective. You can't be subjective. And this is basically an open-label trial. You know what you got. You know if you had TAVR surgery. So hospitalizations can be more subjective. Now, the other trial used hospitalizations, but their data was so good it doesn't really matter. They beat them in all levels, just like we beat them in all levels. And so we didn't use hospitalization. We used 2 years because we wanted what we thought was a stronger endpoint for the low-risk population. We used Bayesian analysis because it allows us to get our data out earlier and bring this therapy to patients who really need it. Now, quality of life, in every single trial that we've run randomized against surgery, quality of life improves faster at 1 month in TAVR that does surgery. But by 6 months, they both have large improvements in quality of life, and it's equal. And it's stayed equal across the spectrum that we've followed. We've followed out to at least 5 years. Well, so the best hope for outcomes is that the survival of TAVR across 10 years is as good as or better than surgery, and that we hope that the quality of life remains as good as or better, which I think that's going to be true, and that these valves are durable. One of the things we worry about biologic valves, even surgical biologic valves, is they can wear out over time. And the older you are when we put them in, the faster you die because you're already older, and the longer the valves last. And so there's a switchover place where we start using biologic valves, and for most surgeons that's somewhere between 60 and 65 years of age. Between 50 and 60, if I talk about mechanical valves versus biologic, the survival is the same. It's a risk of anticoagulation and bleeding for the mechanical valve, the risk of deterioration and having a redo procedure for the biologic valve, which used to be redo aortic valve replacement, now it's transcatheter valve and valve. So, you know, if a patient comes to me and they're a candidate for a biologic valve, I think I really need to have a conversation with them about what's out there. We have data out to 6 and 7 years now on these valves, and the durability seems to be absolutely as good as surgery.